Hi, everyone. Welcome back to Clinician's Brief, the podcast, where we get to explore the conversations behind our Clinician's Brief content. I'm your host, Dr. Alyssa Watson, and today I am sitting down with reproductive specialist and Oregon State University professor, Dr. Michelle Kutzler. We're going to be talking about a case of prostatitis in a Bernese Mountain Dog. And so we're going to use this case to illustrate the approach to diagnosing and treating chronic prostatitis, as well as explore some of the long-term management and prognosis for dogs with this condition. Thank you so much for joining us today, Doc. How are you doing?
Great. Thank you very much for this invitation.
Yeah, we're really excited to dive into this case. But before we do that, would you mind just giving a little background about yourself? Let us know how you got interested in repro and how you ended up at Oregon State.
Absolutely. So I'm originally from Washington, and I credit my Washington State animal science professor, Ray Wright, for my interest in animal reproduction, because before that I thought I was just going to be a horse veterinarian. And his class really changed my life. Because of that, I fell in love with the topic of animal reproduction, and kind of went on a path towards becoming a theriogenologist after that. I ended up back at Oregon State after finishing my residency and PhD at Cornell. It was as close as I could make it back to home for me, being from the west coast of Washington State, and I've been at Oregon State since 2002, so 22 years now. Woohoo!
Yay! I graduated in 2003, and so 21 years in practice now. And funny enough, I also thought that I was going to be an equine vet, but things, change a little bit over the years, and I ended up kind of going more exclusively towards small animal, and then ended up with this job with Clinician's Brief about 10 years ago. So you never know where your DVM is going to lead you, right?
That's true. That's true.
So, well, let's talk a little bit about this case. Okay. The dog in this case did start showing clinical signs after another dog, a female dog in the home, came into estrus. So what were those presenting clinical signs?
This was an 8-year-old, as you mentioned, Bernese Mountain Dog. He was intact because he was a show dog, but he was still being used for breeding. I don't remember from the owner if the female dog that was in heat was intended to be bred to him, or if she was just another female dog that she had in the house. But about a week after she came into heat, the owner noticed some blood dripping from his prepuce. And of course, anytime I think any owner sees blood coming from their animal, they get pretty concerned, as they should. But he was otherwise normal, so behaving normally, normal appetite, no GI signs, really no other urogenital signs either.
Well, is that pretty typical history then for dogs especially with chronic prostatic disease, or do we sometimes see this present, with other inciting factors or other clinical signs?
Well, it's certainly not an uncommon history, but dogs with benign prostatic hyperplasia don't even need to have an estrus female in order to kind of initiate the clinical signs associated with chronic prostatic disease. And so the I would say the most common symptom or clinical sign that we see with dogs with benign prostatic hyperplasia is blood coming from the prepuce, blood in the urine, or maybe the owner notices blood on bedding after the dog has been laying down. But typically this is an asymptomatic condition because the dog, as he ages and his prostate becomes larger, it falls cranially and then ventrally into the abdomen, so it doesn't remain like kind of in the pelvic canal where it can cause problems with urination and defecation, typically what we think of with prostatic diseases in men, for example.
Sure.
The clinical signs of benign prostatic hyperplasia and chronic prostatitis really can't be separated at all. I mean, they're that really we have to do additional diagnostics to determine if there's a infectious component or not. But I do want to take a step back and say that there are other infectious causes of prostatic disease, and I think you have a question coming up for me about this later on. But the acute prostatitis is typically a young intact male dog disease, whereas chronic prostatitis, which happens secondary to benign prostatic hyperplasia, is typically an older male dog disease. And with acute prostatitis, these dogs present with extreme abdominal pain. So often clinicians are thinking, foreign body or something else that would cause clinical signs associated with acute abdomen syndrome. And that's completely different than what we see with chronic prostatitis.
Yeah, you have to remember with those acute abdomen cases, there's so many things even outside the GI tract that can present all the same way. What about other urinary diseases? I know I had a case of a urethral prolapse where the dog came in. It was an intact male dog with a urethral prolapse, and there was quite a bit of bleeding from the preputial area. It was a little shocking to me.
Yeah, absolutely. So I think that really there are several other urogenital diseases that could cause bleeding from or dripping blood from the prepuce. Even just a urinary tract infection might present with a few drops of hematuric. Urine, dripping out after urination. So something as maybe as simpler, one might think, common as a urinary tract infection. You already mentioned, a prolapse of the urethra. Male dogs, even like neutered male dogs, can have pathologic fractures of their os penis bone, and that can cause bleeding from the urethra, and then of course other prostatic diseases. So I mentioned benign prostatic hyperplasia and chronic prostatitis, and I've briefly mentioned acute prostatitis, although we don't see these symptoms associated with acute prostatitis. But probably the next more commonly thought of prostatic disease would be some sort of prostatic cancer, and actually we don't see um, you know hemorrhagic prostatic discharge associated with that.
Interesting. Um, What information, one of the very first things, certainly if I have an animal that comes in with hematuria, one of the first things I want to do is do a urinalysis. So, what information does a urinalysis provide? But I think really more importantly, what information does it not provide when we've got, bacterial prostatitis on our list as opposed to cystitis or, like you said, that benign prostatic hyperplasia?
Right. So a urinalysis doesn't really differentiate between the origin of the infection in an intact male dog. If you the urine that you collect is going to contain prostatic fluid, and actually sperm, for that matter. So vas deferens secretions in an intact male dog, and so when a dog is not ejaculating, sperm and prostatic fluid just naturally retrograde go into the prostate, and that's why infections or um, hemorrhagic prostatic fluid ends up in the urine, and that's where we would see it if we were doing a urinalysis. Um, Typically, these dogs that present with hematuria, it it's pretty gross hematuria. In some cases, very frank blood, and one of the kind of differentials I didn't mention before, of course, for hematuria might be even um, uh, a urolith, and again, anything that would cause trauma to the urethral or uh, bladder, mucosa can cause bleeding. But in a case like this, you really aren't going to. What you're going to see is uh, many red blood cells, especially if you do a sediment analysis. There might be so many red blood cells that it's hard to even determine if there's white blood cells there, and the white blood cells may contain phagocytized bacteria. Again, the most common bacteria we see in these cases is E. coli, so there would be Roche bacteria, but um, uh, how there's really no way to differentiate that on a urinalysis alone. So because of that, when I see what I would consider clinical signs associated with a urinary tract infection in an intact male dog, chronic prostatitis is going to be much more likely than a UTI in with that signalment. And I think that that's an important message, for veterinarians, because at least in our country, we don't really see that many intact male dogs unless you're a reproduction specialist or working with a lot of breeders. So it naturally falls, down on the differential list, with the other zebras. But if it's an intact male dog, that's going to be much more likely than a more traditional urinary tract infection. And so, the real question is how do we um, how do we separate those two, right? And
Mhm.
what I tell folks is, if you're not going to definitively diagnose it, which you need a prostatic fluid sample in order to do that, then you should treat it as though it's a chronic prostatitis until proven otherwise, right? Because I think what happens far too commonly is veterinarians will treat it as though it's a urinary tract infection, and the clinical signs, the hematuria, seems to resolve for the period of time while they're on antibiotics, but then 2-3 weeks later, hematuria recurs, and so then they treat it with another antibiotic, and it seems to resolve, and then 2 to 3 weeks later it seems to recur, and then by the time I get a chance to do a semen culture on this dog, um, it still is E. coli, but now it's resistant to the types of medications that I would typically use, which puts me in a really tough
Mhm.
position too. And so, how do we definitively diagnose it? Well, I mentioned before, doing uh, a collection of the prostatic fluid, and that can really be done in one of two ways. Most intact male dogs are uh, relatively willing to donate a sample of prostatic fluid in the course of a semen collection. And um, how we do this aseptically is we use one container to collect the first and second part of the ejaculate. That's the part of the ejaculate that would contain the sperm. And in that uh, beginning part of the ejaculate, any normal flora bacteria that might exist in the lower urethra essentially get washed out. So by the time you get to the third fraction of the ejaculate, which is the prostatic fluid, what is coming out of the urethra is um, is is aseptic, or it's whatever is coming out of the prostate, and just being careful not to touch the mucosal surface of the penis or prepuce to whatever collection container you're using. But you can use a sterile urine collection cup, which is got a very wide lid to it, and pretty easy to kind of aim the secretions into, and then you don't need a whole lot.
So that's, I mean, just a really good pearl, especially about, when we have this presentation, to really assume that you're dealing with prostatitis, as opposed to just a run-of-the-mill cystitis. Certainly for me, just like you said, I'm in general practice. I'm in general practice on the West Coast. I really don't see a ton of intact male dogs, and so just to remember that signalment is very, very important. And it's been a long time since I've collected a dog. Very early on, I did some AI and some repro work, but it's been a long time since I collected a dog. So that was a nice refresher too on, the different fractions. We're going to talk a little bit more about what was cultured, in this particular patient. You've already talked a smidge about E. coli, but I also wanted to just highlight the fact that there was an ultrasound done of this dog's prostate, because I do think ultrasound is getting, quite a bit more common in general practice. So if we could take just a second to go over kind of the typical ultrasonographic findings in dogs with prostatic disease, that would be wonderful.
Absolutely. So again, one of the most common uh, findings that we see in older male intact dogs is uh, ultrasonographic findings that are consistent with benign prostatic hyperplasia. And so, because the prostate is hyperplastic, it's going to be larger than normal. And there are several charts available in ultrasound books that you can compare to, what normal would be for this weight of dog. But the prostate, because of the influence of androgens, will kind of continue to grow slowly over time. And one of the side effects of this hyperplastic growth is some obstruction of the prostatic ducts within the parenchyma. And so this results in cyst formation. And these cysts can be tiny initially, 1 or 2 millimeters in diameter, but then they can be quite large, and these cysts can coalesce and then form into large cavities, and sometimes these cavities are so large that it almost looks like there's just a small rind of normal prostatic tissue, if you will, that's surrounding this large, cyst inside the prostate lobe. With chronic prostatitis, again, it doesn't have to be cystic. Typically, again, we see an enlarged prostate that's going along with prostatic hyperplasia, but we see that the appearance is more hyperechoic, and this differentiates itself from acute prostatitis. Again, the clinical presentation of the two cases is such that I don't think that you'd ever have a reason to differentiate the two based on ultrasound findings. But with acute prostatitis, the prostate is hypoechoic, and it's also not enlarged. So those are like the two main ways to differentiate between chronic and acute prostatitis. Occasionally, we will see mineralization with chronic prostatitis, and I know that clinicians may have remembered from veterinary school that if there's mineralization in the prostate, that must be cancer, and certainly we do see mineralization in cases of prostatic adenocarcinoma. But with chronic prostatitis, due to chronic fibrotic changes that are occurring from the inflammation, we will see some occasional dystrophic mineralization, and that is again one of the reasons why the appearance of the prostate with with chronic prostatitis is a very heterogeneous. You'll see black anechoic appearing cysts, and maybe some hyperechoic inflamed tissue, and maybe even very bright white echoes with some mineralized tissue as well.
And then do you ever recommend, I mean, you just said we can't really rely on the mineralization or things to differentiate between this and something like cancer. Do you ever recommend aspirating or biopsying the prostate, or doing like a prostatic wash to help us diagnose?
Yeah, so I had mentioned previously that there were two ways to collect prostatic fluid sample. One of them is just a collection of the third fraction of the ejaculate. The other would be to do a prostatic wash, and this, of course, requires at least heavy sedation. But I think that more clinicians are comfortable with passing a urethral catheter and collecting a sample through prostatic wash, and this is an entirely acceptable way of collecting a sample if you're trying to collect prostatic fluid for analysis. I wouldn't recommend ever aspirating or biopsying the prostate if it was infected, and I think that's hopefully is clear to folks why the potential risk for spreading the infection. Right now it's contained within the prostate, within the prostatic capsule, so you don't have any risk of peritonitis, but following direct puncture of the prostate, either with an aspirate needle or biopsy, that would be a concern, and just to avoid the risk of iatrogenic trauma. The other thing too is that the hyperplastic prostate is highly vascular, which is why there we see bleeding into the ejaculate or to the urine, and hemostasis might be very problematic after even doing an aspirate. There certainly would be no way to control the hemostasis externally, and so um, uh, again, because other more serious conditions of the prostate, such as prostatic adenocarcinoma, present so differently. I think that if you're seeing evidence of a hypervascularized prostate, we treat that condition first, and then and then go in for maybe an aspirate or biopsy after that, just so that you don't have problems with hemostasis or again iatrogenic infection in the abdomen.
Sure. Now, you already mentioned that E. coli was cultured from this dog's prostatic fluid, and that's really not surprising. It is the leading cause of bacterial prostatitis, and I think you've really already kind of explained too why we simply can't use a urine culture just to choose antibiotics. Why we need to look at a wash or look at the fraction of the ejaculate, and culture there. But what other organisms can we see that cause prostatitis?
Yeah, so E. coli is 95% of the time what is cultured, so that's why we say that it's the most common organism. But there have been reports of various staph species and strep species cultured from in chronic cases of chronic prostatitis, even mycoplasma species. There's been at least one case report of brucella being cultured out of prostatic fluid, and there have even been reports of fungal prostatitis in dogs. So these are all really, what I would call zebras. They're really be on the lower end of your uh, uh, the likelihood, but still potentially possible. And if it's an intact male dog, it's always a good idea for your own safety, for the safety of your staff, to make sure that the brucella status is negative on that dog too.
Yeah, that's a very good reminder as well. Thank you for that. When you've got a challenging case in front of you, you could spend your lunch sorting through cluttered search results and a shelf full of outdated textbooks. Or you could find what you need to know in seconds, all in one place. By combining concise diagnostic and treatment information, algorithms, and pet owner resources with the drug information veterinarians trust, Plums Pro is ready to change the way you spend your day. This groundbreaking new platform is streamlined, easy to use, and continually updated to keep you delivering great care with confidence. Now you've got one less reason to eat lunch at your desk. Get acquainted with the all-new Plums Pro at plums.com. So let's talk a little bit about antibiotic choice, because this is something that is really important, and one of the reasons we really need to differentiate, like you said, prostatitis from cystitis. Beta-lactams, they achieve very, very high urinary concentrations. I use them all the time when I'm treating bacterial cystitis, especially cystitis caused by E. coli, but they're not the best choice for prostatitis. Why?
Yeah, so that is because of this prostatic kind of capsule that I was talking about, and what many people refer to as the blood prostate barrier. This tissue barrier prevents the diffusion of drugs, specifically those that are highly protein bound in the plasma, from entering the prostatic fluid and parenchyma. And so, in order for a antibiotic to cross into the prostatic parenchyma, it needs to be able to, of course, cross the prostatic barrier, and so it has to be lipophilic, because protein bound drugs are just not going to enter the prostate. Drugs with low lipid solubility. So you had just mentioned the beta lactam, so ampicillin, penicillin, uh, very weakly cross into these areas. Drugs that have a basic pH, just for example, erythromycin, sulfamethoxazole, they easily diffuse into the prostate gland, but that's because they're more basic and the prostate gland environment is more acidic. They use kind of an ionic pathway in order to get into the prostatic tissue. It's really interesting because this information about kind of the blood prostate barrier and the difficulty for some commonly used veterinary antimicrobials to get in the prostate is not new information, but there was a survey of clinicians a few years ago that was done, specifically asking which antibiotics that they would use in order to treat prostatic diseases in dogs, and 30% of them said they would use Clavimox, which has very poor penetration into the prostate. So I think that is a good good information. Really, there are two drugs that we more commonly use in veterinary practice that are lipophilic, that cross readily into the prostatic parenchyma, and those are chloramphenicol and enrofloxacin. And chloramphenicol is just not effective against gram-negative bacteria like E. coli. So that really leaves us with enrofloxacin. And there, I don't want to say that this is in the past, but there was a big phase, I think, when veterinarians thought that ciprofloxacin was better than enrofloxacin because it was this drug that was used in people and newer, and we use enrofloxacin in veterinary medicine. But actually, studies have been done specifically comparing the penetration of enrofloxacin and the other fluoroquinolones into the prostate, including ciprofloxacin. And enrofloxacin has a much higher rate of penetration. And actually, ciprofloxacin at the common dosages that we use wouldn't even be sufficient in order to treat an E. coli infection in the prostate gland.
Yeah, so we have to consider not only, is the organism we're trying to treat susceptible to the medication, but is that medication going to even get where it needs to go in order to treat it? And I think that's
Precisely.
where sometimes we have that mismatch. You had kind of mentioned that, sometimes you're seeing these cases after they've been managed, been on several different courses of antibiotics. Are we seeing more infections that are resistant to enrofloxacin, like to the fluoroquinolones that we really need in order to treat these?
Yeah, so I actually had another older, this happened to be a Swiss Mountain Dog patient. I didn't have as much diagnostic information on him, so I didn't choose to use him for this example. But he was 10 years old, and he presented to me after being treated with several courses of antibiotics for what turned out to be chronic prostatitis, and his organism was resistant to everything. There was no susceptibility to any drug that our diagnostic lab could test. And so we just treated him by eliminating the androgen source. And we followed him up with every other week CBCs and ultrasounds because we were concerned if we weren't also treating for the bacterial infection, could we end up with a prostatic abscess? What could happen? But there was no antimicrobials that were that were sensitive to the organism anymore, not even intermediate sensitivity. So hopefully none of your listeners find yourself in this situation like we did, but at least in this one case that we managed, we were able to successfully resolve his chronic prostatitis by, in his case, we ended up castrating him to remove his androgen source, but then again, carefully monitoring him while his prostate gland was involuting for the potential of a prostatic abscess forming.
We're going to talk about that too. But before we do talk about that, I just did want to kind of touch on this duration. I've definitely seen a shift towards like these higher doses, shorter duration antimicrobial therapy for lots of different conditions. Urinary tract disease being one of them, but also like pneumonia and a few other things. But this case, had a 6-week course of antibiotics. And so can you just go through the rationale and the justification for why we do actually need much longer courses than we are seeing with some of these other disease processes?
Exactly. So when we treat chronic prostatitis, we have to treat the underlying condition, which is benign prostatic hyperplasia. If you just treat them with antibiotics, they will develop a chronic prostatitis again because the underlying condition still exists. So, how do we treat benign prostatic hyperplasia? Well, we need to remove the androgen source, and in most situations, the method is castration, because you removed the testosterone because the testes are no longer there. But if this was a breeding dog, or the owners were reluctant to castrate this dog for whatever reason, the medical alternative is to administer finasteride. Finasteride is a 5-alpha reductase inhibitor, and specifically what it does is it prevents the conversion of testosterone to dihydrotestosterone, which is the biologically active form of testosterone. So, with dogs that have benign prostatic hyperplasia and are intact, if you give them finasteride every day, their prostate gland will gradually shrink down, or what we could say involute, to the size of that of a castrated dog over time. But this takes time. Um, Castration, at a minimum, takes between 2 and 4 weeks before you start to see some changes in prostate size. But when we use finasteride, it takes about 6 weeks before we see a significant reduction in prostate size. And so that's why we need to keep them on antibiotics for this period of time while we are reducing the size of the prostate, so that any potential micro abscesses that could develop as the prostate gland is involuting, we have antiseptics, or antimicrobials on board to uh, prevent, or that's what our intention is to reduce the risk of that, those like maybe micro abscesses from forming.
Sure. And then in this case, that was the case with this dog. The owners did not want to neuter him, and so he was treated, with the finasteride. And this would then need to be lifelong for that. So, just if you have one of those patients, what type of monitoring are you using on those if you're on these like long-term, lifelong medications?
Yeah. So, finasteride. Uh, as far as we know, again, a lot of this is drawn from the human literature. It is relatively safe as far as hepatic and renal. With respect to hepatic and renal safety, it's certainly used again in human medicine, and in with other comorbidities, so hypertension, other endocrinologic diseases, other um, uh, you know behavioral, or cognitive medications that the human patients might be on. So I mention all these things because often our veterinary patients they're not just on one medication.
Mhm.
They might be on multiple medications for a variety of disorders, especially an older dog. So, based on the best information that we have available right now, there doesn't appear to be uh, any long-term risks for keeping dogs on finasteride, and there's certainly no interactions with, again, more commonly administered medications to dogs. And it used to be, I would say, and I don't want to call it contraindication, but one of the most challenging things for owners was the cost. Um, Merck was the first company to come out with finasteride, and it was marketed under two brand names: Propecia, that was for male pattern baldness
Yeah.
for men,
Mhm.
and that's the 1 milligram strength of finasteride, and Proscar, which is the for male, for human benign prostatic hyperplasia, and that's the 5 milligram strength. And so for dogs, really regardless of size, so this could be a 5 pound Yorkie, or a 110 pound Bernese Mountain Dog, we give them the 5 milligram tablet once a day.
That's really interesting. I did not realize that dosing was not based on size. So, yeah. Well, that is all. That's been wonderful. Thank you so much for going through this case with us. And I actually learned a lot. I think the next time, I have a patient that fits this signalment, which, like I said, is not too often that I get, an older intact male dog in, but I am going to be sure to keep this, a lot higher on my list. The last thing we like to do on our show is to play a little game. If you would join us, we have just a couple would you rather questions. It's just for fun. It's something to kind of wrap up and give us a little treat at the end of the episode. Would you like to play?
Yes.
Okay, excellent. Would you rather hunt for an ovarian remnant in a tiny Yorkie, or would you rather perform a C-section in an obese Mastiff with 15 puppies?
C-section any day.
C-section. Oh, puppies are the best. Would you rather be on call on a major holiday or on Friday the 13th?
Holiday, definitely.
You're superstitious. Don't give me the Friday the 13th or the full moon.
Yeah.
Okay. Would you rather continue practicing medicine but give up teaching, or continue teaching but no longer practice?
Oh, dear. That's a hard one. I think that I would rather give up teaching because I feel like every time I'm in the exam room, I have an opportunity to teach a client.
Yep, I agree with you 100%. Like, there's so much teaching that goes into just practicing. So, all right, last one, and we'll make it a silly one since that last one was kind of hard. If you had to preg check a centaur, would you ultrasound the woman's abdomen or the horse's abdomen?
Oh my gosh, that is a funny one and a silly one too. I guess if I'm doing the ultrasound, I could start on the women's abdomen and then just keep following it back caudally.
Until you find what you're looking for.
Right. And if you don't find a fetus and all of that, then you can say there's no pregnancy.
Well, that was a great answer. Thank you so much. Thank
Sure.
you again for just talking to us about this really important topic. And I want to thank our listeners at home. I hope you found today's discussion really helpful and informative. I know I did. Thank you for joining us for today's episode of Clinicians Brief the podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts, or drop us a line at podcasts@vetmedics.com. Clinicians Brief the podcast is a VetMedics production, produced by Alexis Ussery and hosted by Dr. Alyssa Watson.